With that said, I am so excited and so honored to welcome Dr. Claire Duvallet as our speaker today. Dr. Duvallet is actually our second industry speaker in the history of our seminar series, which is very exciting to showcase the applied side of epidemiology. She is a founding data scientist at Biobot Analytics that many of us have heard of, which is a startup that is transforming sewers effectively into public health observatories. And as a technical lead on Biobot's data science team, Dr. Duvallet provides high-level technical guidance across a variety of different projects and programs. And in her role, she works very closely with the data science team as both a contributor and an advisor on the R&D projects that Biobot works on, as well as serves as a technical advisor and a representative on all sorts of cross-company programs, as well as bridges scientists and software engineers within Biobot as a liaison. Prior to joining Biobot, Claire received her PhD from the Biological Engineering Department at MIT, where she studied the relationship between the human microbiome and health and disease, and then also worked on the precursor to Biobot, developing wastewater-based epidemiology approaches for public health impact. And then prior to that, she studied biomedical engineering at Columbia University, and then spent a year working at Engineering World Health in Cambodia as a Luce Scholar. Dr. Duvallet's talk today is entitled Supporting and Scaling Nationwide COVID-19 Wastewater Monitoring. And with that, thank you very much for joining us, and please take it away, Claire.
Cool. Thanks, Nicole. Thanks for that intro, and thanks everyone for being here. I'm super excited to share about our work. So, okay, you can see the full screen, no Chrome tab. Cool. All right, so yeah, today I'm excited to talk to you about kind of some of the work that Biobot has done, how we did it, and then also spend some time talking through some of the things we've learned along the way. So Biobot Analytics is a wastewater epidemiology company transforming sewers into public health observatories. The concept is really simple. Everybody pees and poops, and when you use the toilet, that sample is essentially a medical sample that's getting flushed down the toilet and aggregated in community sewers. So just like when you go to the doctor's office, sometimes they'll take a urine or stool sample, run some tests that tell you something about your health. We view wastewater as essentially a community level urine and stool sample that can likewise tell you something about a community's health. Biobot Analytics was founded in 2017 at a time when wastewater epidemiology was still really niche in the US. It was a well-established field in Australia, Europe, and China, but in the US it was still very small. It came out of an academic collaboration at MIT between the bioengineering departments and the urban studies and architecture department. So that's kind of where our two founders met and kind of came up with this idea to start this company. So in 2017, at the time, the largest public health crisis facing the United States was the opioid epidemic. And so that's where Biobot started. We started by measuring opioid metabolites, so metabolites that you excrete after you consume licit or illicit opioids, as well as treatment drugs. And we were measuring these at the manhole level within cities. Then COVID hit and everything changed, as everybody knows. As a public health company, we knew that it was really important to be able to respond to COVID-19. So basically, as soon as the first reports of the virus being shed in stool were published, which was, I think, almost exactly a year ago, or 3 years ago, we were kind of all hands on deck, adapting our technology to respond to this emerging pandemic. We partnered with the same academic lab at MIT, Eric Alm's lab, that Biobot came out of, to develop and validate the wastewater assay. So we were the first group in the United States to report the SARS-CoV-2 virus in wastewater. And this all happened really quickly. We started this work, I think, in mid-March, and then we had a preprint out on March 25th, and that's kind of when we launched our first national program. So that first nationwide deployment was in March and through the summer of 2020. So again, we partnered with this group at MIT to offer this service pro bono. And this really helped us kind of scale the technology rapidly with very few barriers to participation. And in doing so, helped us really validate a lot of the technology and the methods. And so through this program, we had about 40 states represented, about 10% of the US population. And we saw that, weekly testing was pretty good. And also kind of the sampling kit and the methods we had were sufficient to get measurements on the virus. Since then, so starting in June 2020, we pivoted to a full service offering. And since then, we've been doing wastewater-based monitoring nationwide. Usually we do weekly sampling across hundreds of locations, though that really depends on the specifics of the program and the partner. We work across all levels of government. So we're currently the vendor for CDC's nationwide contract. So through that, we're in all 50 states, a handful of US territories, as well as tribal communities. And that's sampling twice a week for about 400 to 500 sampling locations. In 2021, we were kind of similarly the national vendor for the HHS version of this project. And then we also work with state programs. So we have a really robust program in Massachusetts, as well as in Maine and Pennsylvania. And we also work with local utilities, so local municipalities whose treatment plants kind of work with us directly. Of course, it's not just us. We're not the only ones doing this. And I think this is one of the most exciting aspects of the past 3 years, is that we've really seen wastewater epidemiology kind of go mainstream. It's now a really vibrant and growing academic field. So you have like millions of papers with case studies, methods development, validation, like variant methods, new methods. It's really exciting to see that academic community really exist in the United States now. And more excitingly, I think we've seen a substantial adoption of this technology in practice. So like in the real world, wastewater epidemiology is a thing. So again, from local municipalities like MWRA in Boston posting the wastewater data and those local communities being able to use it, all the way to having a national national public health surveillance program. So the CDC National Wastewater Surveillance News is really exciting that it exists. I think public health surveillance systems usually take decades to kind of stand up and get adoption, and this happened extremely quickly, and really is a testament to kind of the recognition of wastewater as a powerful public health tool. Just to like kind of really hammer this point home, I think it's just so exciting that wastewater is really integrated into public health surveillance, both on the public health side of things. So this is a screenshot from a biweekly call hosted by the CDC, and they actually use wastewater's data as part of the introductory like state of the pandemic overview. And so we're always really excited to see our data pop up there, like for the CDC. Excitingly though, it's also really used by the public. So I know probably everybody at Biobot gets text messages from their friends asking them like, hey, what's going on with the wastewater? What do you think? And so I think it's really cool to kind of see that adoption. So that's kind of a brief overview of what we've done. And so now I want to talk about how we actually did it. Are you seeing blue things on my screen?
Yes.
Let me try again. I changed my all right, you can see it, yes?
Yeah.
Okay. Cool. Okay, so we're back. So that's kind of a brief overview of what we've done. And now I want to talk about like how we actually did it and how we do this. And actually like the biggest thing I've learned throughout all of this work is not actually science. It's really that the logistical and operational considerations for doing something like this are super critical. Like it's one thing to have an idea and to, publish a paper about it. It's something fundamentally different to actually put that out in the real world and do it at scale. And so I want to take a moment to talk about that. So how it works from the perspective of a participant in the program, we send them a sampling kit. It's just, a box with some tubes in it and some information about how to take the sample. Then the sampling treatment, like the treatment plants or the sampling operators will collect the sample. So usually they take 24-hour composites, which is essentially, a little bit of sample every hour that's put in the same bottle and shaken up and then poured into our bottles. They'll also log some information about that sample and then mail it back to our lab. Our lab is in Central Square. We process everything in high throughput, so we're using kind of standard qPCR detection methods. And then we process that result and kind of contextualize it with our existing data set to report back more than just a wastewater concentration. And then finally, we report that back to the participants, which is something really important for us as well. So one of the things we've learned is that actually really collecting the metadata that we need to do the data interpretation is one of the biggest challenges. So for each sampling location, we need to know some information about kind of like, what's this location like? What's the sample like? You know, where is it located? So we can link it back to cases, and what's the population, flow rate, and things like that. For each sample, we also need to know, right, information about that sample, like when was the sample collected? Where was it collected from? What was the flow rate on that day? Kind of what type of sample was it? And so getting this information in a really standardized way has been a huge effort on our part. So we've built forms that sampling operators can use and that have a little bit of validation. Though one of the really big lessons we've learned and had to learn over and over is the balance between comprehensive data collection and the ease of collecting that data. So, right, you want to make it easy for folks to be able to fill out the information. And so, for example, some locations don't have flow rate until, you know, a day or two after they collect the sample, just because of how their data systems work. And so if you wanted, you know, we really want flow rate from every sample, but we also don't want to prevent those locations from being able to input the data. So I think this is like a tension that's a really big challenge as we're designing these things, and again, trying to really scale nationwide. Something else we've learned is that like actually QCing this sort of information is as, if not more important than QCing the lab results, right? Because it's critical, for example, to know when a sample was taken if you're going to do any sort of interpretation. If someone logs a sample that's like in the future, right, there's no way to really use that and correlate that with the cases and really build these models. And so really there's a lot of thought and focus and energy put into making sure that the metadata we collect is also as accurate as possible. So like I said, samples are collected by the operators and then mailed back to our lab. We use really standard quantification methods. So we do, you know, we pasteurize the wastewater samples first to inactivate any viruses for kind of biosafety. Then we're a series wastewater epidemiology center of excellence. So we use their nanotrap particles to do the virus capture, and then we use another standard kit for RNA extraction. And finally, we use qPCR to quantify both the SARS-CoV-2 virus as well as a fecal control and a few other controls. We deliver our results back to the participants, which again is something that's been really important to us from the beginning, is making sure that these treatment plants that are putting in the effort to collect these samples and send them back to us are seeing the data in a way that they can understand. And so we send participants a PDF report that has kind of the lab results as well as some other visualizations to help them contextualize what these wastewater concentrations even mean. We also put a subset of our data on our website as part of our public visualization. So participants who opt in to having this data shown, which can include kind of a subset of our paying customers, a subset of the participants in our state and federal programs, as well as participants in the Biobot network, which is a free sampling program to kind of supplement our data set. And here in the visualizations, it's really public facing. And so we're really focused on smoothing and averaging out the data so that it provides really interpretable views of kind of nationwide trends. And then finally, we also contribute data to the CDC's internal data system, to the National Wastewater Surveillance System. Many of our partners submit their data to CDC directly, and then we also submit data for our federal contract with them. And that data is included on their website on the CDC COVID data tracker alongside wastewater data from non-Biobot programs. So that's a little bit of kind of how we do it, right? Really, there's a lot of logistical and operational constraints, which again are really important in order to be able to do this at scale. That said, that's not the only thing we've learned. We've also been able to do some cool science. So I do want to talk a little bit about that for the rest of the talk. So I'll share kind of 4 categories of stories about, you know, things we've been thinking about for the past 3 years and kind of where we've landed. And I hope at least a subset of them will be interesting to some of you. So first, data interpretation, just kind of general data interpretation questions we've gotten and where we're at. So early on in the pandemic, a question, you know, we, like a lot of people, including us, were really excited about the potential of wastewater as a leading indicator, right? So the idea is that you shed virus before you start showing symptoms. And so maybe that means that the signal you see in wastewater will precede the signal you see in cases, giving you kind of a heads up of changing dynamics. So, right, this idea was really appealing. And so we always got the question, like, what is the lead time of wastewater? How many days does wastewater lead cases by? So we looked into this, and like all good epidemiology questions, the answer is it depends. So we looked into this in 2021. We looked at kind of a handful of studies that tried to quantify this lead time, and sure enough, it was really variable across studies and even sometimes across sites. We also saw that the lead time really depends on like how you're calculating it or what you're looking at. So one of the common ways people find, try to figure out the wastewater lead time is they'll take the wastewater time series and the case data, and they'll shift one or two of the time series by a few days. They'll calculate the correlation, and they'll see like what amount of shift maximizes that correlation. And so that's kind of what this plot is. And you can see it's like, there isn't like one maximum, right? Like it's just kind of flat. And so this kind of puzzled us. And then we looked, okay, depending on what sort of like case metric, incidence metric you're looking at, you might get a different answer. And then also, like, depending which slice of data in time you're looking at, maybe the lead time will be different. But that actually makes sense, right? You wouldn't expect the lead time of wastewater to be the exact same in every context over every period of time. And so this kind of led us to articulate this idea that really the lead time between wastewater and cases depends on a lot of biological and health system factors, right? So biological factors like the proportion of infected individuals who actually shed the virus, delay between when you start shedding in your feces and when you have symptom onset, and maybe a variant-specific shedding dynamic, so how variants change these delays. On the health system side, right, you have just testing availability. How available are tests, and can people actually get tested? Are people actually get tested? Are they seeking that healthcare? And then also, like, just logistically, the turnaround time for these clinical and wastewater tests. So you can imagine two communities, right? Like community A, everyone is getting a clinical test every day, no matter if they have symptoms or not. Clinical and wastewater tests have the same turnaround time. And so here, what you'd expect the lead time to be is basically the time between the first day you start shedding in stool and the first day you test positive. And so assuming that you shed in stool about the same time that you shed enough to get a positive test, and the turnaround time is the same, like probably in this community, wastewater has zero lead time over cases because you have such good case data. In community B, which is probably closer to the reality, let's say you don't really have active case finding, testing is only in response to people with symptoms, and clinical tests have a longer turnaround time than the wastewater tests. Here, the lead time would be basically, again, the time between the day you first start shedding into the wastewater and the day when that person receives a positive test. And receiving that test basically requires that they show symptoms, they get a test, and then they get their test result. And so in this situation, wastewater could have up to a week of lead time. And so you can see, right, like in the United States, we've kind of gone back and forth between being community A and being community B. And so of course it makes sense that the lead time would change. Also, kind of going deeper into the rabbit hole of this question of like lead time, it also really depends on the specific application of wastewater surveillance. So what it means is different depending on what you're trying to do. So one of the applications for wastewater testing is really just as an early warning for disease activity. Is there any COVID in a community? So we see this a lot in the kind of building setting, or like, right, when you have a localized community and you're trying to catch outbreaks. Or in communities with very low incidence. So Australia had this for a little bit. They had really, really low incidence. And so they would usually not see SARS-CoV-2 in the wastewater, and then sometimes they'd have it detect. And so here, the lead time is really primarily dictated by the timing of the clinical and wastewater testing. So it's kind of, it has a lot to do with those relative turnaround times. Another application of wastewater monitoring is really just as an independent measure of population health. So I think this is really the primary use case and the primary example that we've seen wastewater used at the community level. Here, the lead time is a lot less relevant or even clear. Like we've been talking, like, yeah, you expect it to change over time. also the 2 time series, like they're not perfect matches, right? There's different dynamics in wastewater in viral shedding. So you might see something different in wastewater than in cases. And so it's not clear that like a single lead time will be best. And again, it might change over time and space. In this application, really lead time isn't the most relevant question. It's really that wastewater's power is as an independent measure of population level trends. So my favorite example, which was published in an EPA report, is I think it was the state of Utah, and they saw that their cases were decreasing, but testing was also decreasing. And so they didn't know, like, are cases decreasing just because like testing is going down, or is it really truly a reduction in burden? And so they looked at the wastewater and they saw that the wastewater was also decreasing. And so that gave them kind of confirmation or additional evidence that like the decrease they were seeing in cases was actually a true reflection of decreased incidence rather than just an artifact of testing. The final application of wastewater epi is as a quantitative estimate of rapid changes. So identifying inflection points. Can wastewater tell you that something is changing, that something is changing rapidly in the epidemic faster and earlier than cases can? This is really hard. I think this is the most technically challenging application of wastewater epi that I don't think we figured out. It requires, really quantitative data and the ability to identify changes rapidly. So if you're looking for an inflection point on the order of days and you only have weekly testing, that data is just not going to be able to find that change. It also requires like a good way to say that things are changing with case data, which I'm not sure that, we really have that robust, those robust models, and maybe we do, and I'm sure the community here would be the ones to know. But I think this one is really the one that would be the most exciting in terms of thinking about lead times. Is like, can you really identify inflection points through the wastewater data, through the case data, and does wastewater give you an earlier view of those changes than case data does? The other thing we think about a lot in terms of data interpretation is really pairing wastewater data with other public health data. So I'll give a bunch of examples here about the wastewater to case ratio, so the WC ratio, which we worked with a grad student at MIT to develop. It's really simple. It's just wastewater concentration divided by clinical cases. And like many things in wastewater epidemiology, the actual number isn't really as important as trends in that number. And so trends in this ratio, can maybe tell you something about changing dynamics, public health dynamics. So for example, if you're getting, let's say you're getting more asymptomatic cases, you might expect to get fewer reported cases. So the denominator would become lower for the same number of viruses in the wastewater, for the same number of true infections. So you have the same numerator, a lower denominator, and so that ratio might increase and might tell you something about kind of case ascertainment. And so you can actually see this when you look at the data. So this is just a screenshot from our website. The blue is wastewater data, the green is cases, and then this is the ratio of these two lines together. Well, actually, it's not these two lines. I'm using CDC case data because it's a little bit better. And so you can see kind of early on in the pandemic, we had a really high wastewater to case ratio. So a lot of infections contributing to the wastewater and very few of those infections proportionally reported. So a really kind of high numerator and low denominator. And then kind of for most of the first couple of years of the pandemic, we were at a pretty like decent baseline. We had a pretty good handle on testing, kind of, it was like pretty stable. And then you had kind of the Omicron surge, and you can actually really see this in the time series. Like you can see it by eye that they really start to diverge. And then they go back down. And then interestingly, over the past year, you've seen the WC ratio kind of creep up. And that makes sense, right? Anecdotally, we know that the testing, folks are testing at home, testing isn't being reported as much, case reporting isn't as good. And so you would expect to see kind of fewer reported cases for each infection that's truly out there and truly contributing to the wastewater. Other ways to think about the WC ratio beyond just kind of case ascertainment and testing dynamics, you might be able to use it to capture short-lived trends. So let's say you get a rapid increase in infections and then cases take a little bit of time to catch up. So maybe like when colleges start, in Boston, you get an influx of students, influx of infections, and then it takes them a while to get tested. So here you'd have more infections, which means you have more virus in the wastewater, so the numerator is higher, and you wouldn't necessarily have an increase in the cases until a little bit later. And so you'd see the WC ratio increase and then go back to a baseline. It could also tell you something about changing demographics of who's infected. So let's say you're getting more young people infected. Probably that means there's more asymptomatic infections, so less case reporting per true infection, right? So you have more total infections, which means more virus in the wastewater, fewer of those proportionally being reported, so you have a lower denominator, and so again, your WC ratio would increase. Finally, you can think about kind of this paired data set to evaluate how vaccination is impacting cases. So, let's say one scenario of vaccination is downgrading symptomatic infections and making them asymptomatic, but it's not reducing the total amount of infections. So because you have the same total number of infections, you'd have the same amount of virus in the wastewater, but fewer reported cases because a lot more of those are asymptomatic. So here the WC ratio would increase. A different scenario, let's say, is that vaccination reduces the number of asymptomatic infections, but not the number of symptomatic cases. You'd have fewer total infections, so your virus, the numerator would be lower, but then because you have a similar number of symptomatic cases, you might expect to have a similar number of reported cases. And so you'd have a lower numerator, the same denominator, and your ratio would decrease. Also, right, it doesn't have to be just cases. You can also do this with hospitalizations, which I think is a really exciting extension of this idea. So instead of looking at wastewater to cases, look at wastewater to hospitalizations. And that ratio might indicate changing disease severity. So if you have a variant, a new variant emerging that's either causing more of the infections to turn into hospitalizations or fewer, you would see that ratio kind of change over time. So that's kind of how two stories about how we think about data interpretation. So wastewater lead time, there is no single lead time, which makes sense based on kind of what we know about biology and healthcare. And then it's also really not the most important question for a lot of applications of wastewater surveillance. And I really believe this, that the power of wastewater surveillance at the community level is really as an independent confirmation of the trends we're seeing. Another kind of thing that I also really truly believe is that combining wastewater data with other data streams really increases the opportunity for insights. So I talked a lot about the WC ratio, how looking at wastewater relative to cases can give you hints about maybe things that are going on and changes that are going on underneath it. And I think we're really excited to think about extending this sort of idea to other data streams. So another kind of big chunk of time that we've spent thinking about wastewater data has to do with normalization. So that's what I want to talk about next. So normalization in wastewater epidemiology really just means adjusting the raw concentrations that you measure so that they better reflect meaningful changes in the community. So one really kind of easy example is dilution. So let's say you have a really rainy day, your wastewater network is flooded with rain or whatever, and so the SARS-CoV-2 concentration you'll measure on that day is much lower than on previous days. But that doesn't mean that you have less COVID in your community, you just have a more diluted sample. And so normalization really is focused on addressing this and making it so that the data that you're seeing is reflective of true trends rather than potential artifacts. So over the past few months, we've been working on kind of figuring out a mental framework for thinking about normalization and for picking, evaluating and picking between normalization approaches. And so I want to kind of give you a sneak preview, and we'll be publishing it on our website pretty soon. So first off, it's important to think about what's the goal of normalization. And normalization can really account for different types of things, which we've bucketed as these three kind of in-lab effects. So things in the lab protocol, any losses happening in the lab, maybe like instrument biases, maybe lab fluctuations, like on a given day, it's warmer in the lab and your enzymes are working better. I don't know. Kind of anything that's happening in the lab that might affect that result and not be reflective of true trends. You also have in-sewer effects. So these are things like degradation, any sort of partitioning between the liquid and solid fractions in the wastewater, and of course, our good friend dilution. And then finally, in human effects. So kind of fluctuating or transient populations, maybe you have a heavy commuter community that has many, many more people during the week than the weekend, or you have an event that's kind of bringing an influx of people into town. And also differences in kind of excretion rates from different drugs or different ways of administering a drug, or different viral shedding rates. So, right, normalization can address any or all of these, depending on kind of the assumptions you're making and what normalization approach you're choosing. So, how do you pick a normalization approach? There's many different ways in the literature to do it. And so how do you decide? And again, here, this is kind of like the core lesson that I've learned at Biobot is that the theory and the logistics really dictate and constrain the possibilities. So it doesn't matter if you have like a super fancy model for normalization or whatever, if it's not practical, it probably isn't the one that you should pick to do something at scale. And so for us, what that looks like, right, the theoretical justification is just like, can you tell a good story and does the story make sense? So, as an example for a population marker, this would be that you want a population marker to be excreted by most people, not have too many non-human contributions, not have too much systematic biases between communities, not be reflective of like the thing you actually want to be measuring, things like that. And then on the practical perspective, what that means is that you want normalization approaches that are compatible with your existing methods. So this is a huge consideration for us because we're kind of monitoring thousands of samples in high throughput, and so we really want to make sure that it's compatible with those existing methods, and then it doesn't add substantial logistical or financial burdens to the existing operations. So like it doesn't require a substantially different sampling kit in order to measure this new normalization thing. So if you have kind of the theoretical and practical justification, you can also look at different normalization approaches in different ways. And so, we think about it in kind of three ways. So some normalization approaches can really directly estimate whatever effect you're trying to correct for. So whether that's the in-lab, the in-sewer, the in-human effects. A lot of work has been done on kind of population estimation models. So measuring something in the wastewater and using that to directly estimate the contributing population to that wastewater sample. This one is really hard because there just really aren't that many gold standards or baselines to validate these models, right? You're like, there isn't like a simulation of a treatment plant that you really can work with and really truly know how many people are contributing to a sample on a given day. So a different way, if you can't really do this, or even if you can, a different way to kind of evaluate a normalization marker is to see, does it improve the representation of external trends that you expect to be there? So essentially, does your normalized time series look better and look more like the pattern you're expecting than the unnormalized? So for COVID-19, this has been kind of where a lot of our effort has been focused, which is just looking like, does normalizing the data improve your correlation with cases? That said, that's not actually going to work for a lot of use cases for wastewater epi, because in a lot of cases, there isn't that gold standard data. There isn't the cases equivalent for, let's say, substance use. And so that's why we have this kind of third axis of evaluation, which is just, does normalization improve the interpretability of the data? This one is purposefully open-ended. I think I'm really excited to be thinking about kind of what are the data-driven ways that we can evaluate how normalization is just making the data better. So some of the ways we think about it are just kind of like, is it reducing any unwanted variability, any noise? Is it removing any like systematic location-specific biases that you know about, right? Like, does it make buildings look more like wastewater treatment plants? Kind of things like this. And I'll say kind of, right, when we're thinking about picking a normalization approach or like, can we do this? There is no one best way to evaluate a normalization. Also, approaches don't need to meet all three of these. They don't need to meet any of them, really. I think as long as theoretical and practical justification is met, I think that's like really actually often enough. And that's really where we've been for a lot of the pandemic. Okay, so how do we actually do normalization? I've been talking about how we think about it. How do we do it? So we've categorized it into kind of two main types. So the first is marker normalization, which is essentially you're measuring something in the same sample and you're using that thing to normalize your data. So this is what we do. We measure a fecal virus called PMMV. It's a dietary virus, so it infects bell peppers, spicy peppers, and makes them ugly. So then they get put into like hot sauces, tomato sauces. So they're pretty ubiquitous in our diet, and they're really ubiquitous in human stool. And so we just take our wastewater SARS-CoV-2 concentration and we divide it by the PMMV concentration. And that's kind of the basis of how we normalize. An alternative like category of approach is something we're calling metadata normalization. And so here you're addressing the sort of environmental effects you want to correct for using some sort of external metadata. So something that you didn't measure in the sample itself, but maybe that you collected from the sampling operator. So the really common one here is flow population normalization. So essentially you take your raw concentration, you multiply it by the flow on that day, and then you divide by the reported population, probably given to you by the sampling operator. So which one is better? We actually get asked this, not as much anymore, but we used to get asked this a lot. You know, some like a high level view of the trade-offs, I think for us, for PMMV normalization, the most important thing is that you can apply this to any type of sample, regardless of access to flow meters. So you can do this for building level samples where the flow is too low to actually be able to be measured. You can do this for manholes. You can do this for treatment plants that maybe don't have flow meters. It's really kind of all you need to do this is the sample itself. And so that's our biggest constraint, and that's our deciding factor. In contrast, flow and population normalization, right, it requires accurate flow and population metadata from your participants, but it doesn't require additional lab measurements. And so for someone like the CDC, who's trying to aggregate data from a variety of labs and doesn't have any control over the methods that those labs are using, I think this is actually probably their biggest constraint and deciding factor. And so I think this is why they report flow and population normalized data, because they can't guarantee that they'll get, you know, PMMV from every lab. I don't know why my computer is. Good, we're good again?
All good.
Cool, thank you. Okay, so like I said, we do PMMV normalization. Does it actually help or hurt data interpretation? And so again, as all good questions are, the answer is it depends. So if you're looking at temporal correlations, so within a sampling location, does normalization improve that location's correlation with cases? So the correlation between wastewater and cases over time, each point is a location. And so this plot shows kind of the difference in the correlation between normalized and unnormalized. And you can see it's like basically centered around 0. So every point is a location, and then these are their correlation results. And so what this means is that within a location, normalization can help or it can hurt that correlation, depending on where you're looking. That said, if you're looking across sites, so now looking kind of calculating for each month, what's the correlation in the state level average cases and wastewater. So if, you know, state Texas has higher cases, will it also have higher wastewater than Massachusetts, let's say? And here, when you look at it, normalization actually does improve the correlation in all but 2 months. And so this kind of also makes sense kind of with how we think about it, but really what this tells us is that in the specific case of PMMV with this, you know, specific protocol at this specific time period, PMMV normalization doesn't necessarily help or hurt within locations, but it does improve your ability to make comparisons across locations. The final thing I'll mention about normalization is about kind of data continuity. So this is something that's really, really important to us at Biobot. We want to be able to show a time series going all the way back to the beginning of the pandemic, and we want to be able to adapt as we learn and as we improve our methods. And so about a year ago, we introduced this concept of effective concentration, which is essentially the raw SARS-CoV-2 concentration adjusted for everything we currently know how to adjust for. And so I've been talking a lot about normalization, right? You have this like very spiky raw concentration. When you normalize, maybe it becomes a little smoother. And let's say you have a lab protocol change that you know, has a systematic bias and everything is now much lower for some reason. So the effective concentration is essentially taking the normalized concentration and putting it back on the same scale so you can have one continuous time series. We call this the effective concentration to avoid lots of jargon. It's kind of like a feels like temperature, right? Where the feels like temperature is both the actual temperature measurement as well as humidity and wind chill and a bunch of other stuff. And so that's kind of effective concentration. And we derive that adjustment factor just empirically. There's nothing magical about it. So that's kind of that story, right? Normalization is how we adjust data to better reflect trends. We proposed a framework for thinking about normalization, which I hope will be helpful to the field. And then at Biobot, we're very excited about kind of our effective concentration. So next up, something we often also think about a lot is representation. So how well does wastewater represent US populations, and what do we do about communities on septic? So we looked at this in 2021 when we were working with HHS, and we saw that wastewater monitoring better represented the age structure and racial demographics of the United States. So if you look at this is the entire US population, this is the demographics of the sites that were included in our HHS project, and then this is the demographics of the vaccinated individuals kind of at that time. And so, from a vaccination perspective, it makes sense to have younger people underrepresented in that population because older individuals are at higher risk for morbidity and mortality. But all age groups can spread the virus, so it's important that your surveillance systems are not skewed like that. And so you can see kind of really close agreement between the demographics of the US and of the sites in our program. On the racial demographics side, right, we've known that Black and Hispanic communities have been disproportionately affected by COVID-19 and are also less likely to be vaccinated, or at least again at the time. And here you can see that actually these communities are slightly overrepresented in our data set, which really shows the power of wastewater as an equitable monitoring tool. Importantly, actually, a lot of these, both the HHS and CDC programs really emphasize monitoring tribal communities, and so made a really big effort to kind of do outreach to those communities and make sure they were included in the data, which I think is really powerful as well. So another question we get on this front is kind of, what about communities on septic? And when we looked into it, actually, we saw that septic is not a critical barrier for equitable wastewater monitoring. So it's true that, septic usage is more common in rural areas, and rural areas tend to be less advantaged. But actually, when you look into it, septic households have higher income and a few other metrics. And actually, septic households are more advantaged than sewered ones. And so it's kind of, Simpson's paradox, where you might assume that because you're excluding septic communities and they're more rural, you might be excluding disadvantaged communities, but actually it's the opposite. The other kind of thing to think about is that septic users still are contributing to public wastewater. So if you're using the bathroom in any building on the public sewer system, whether that's at work, at the library, at your friend's house, you're contributing to that wastewater data set. Also, just from experience, right, we've been able to do wastewater monitoring at the building level in states with a lot of rural and septic users, and we've seen wastewater monitoring still work. And so kind of where we're at with this question is that if you're sampling community wastewater, it'll probably give you a picture that's equitable or overrepresents disadvantaged populations when thinking about kind of how septic users contribute to that. So then, yeah, the last story kind of is what happens next? What do we do beyond wastewater treatment plants and beyond COVID? So beyond wastewater treatment plants, we have been doing building level monitoring, and I think this is a really powerful application of wastewater surveillance, but it's also much more challenging in terms of data interpretation. So, right, not every virus detection in the wastewater merits a response. You might have visitors coming to the building that are shedding virus that maybe aren't really transmitting in the building because they're not staying very long. You're not going to detect every infected person. So not everybody might use the restroom in the building. They might not be shedding enough to detect to get a detection. And trends may not be reliable. You have orders of magnitude of different shedding between individuals, and infections can spread really rapidly. And so kind of looking at that trend time series doesn't make as much sense at the community level, where a lot of those things are averaged out because you're looking over thousands, tens of thousands, hundreds of thousands of people. And then finally, at the building level, representative case data can be really hard to find, even harder than at the community level. So kind of all of these things together made us focus less on looking at wastewater as a readout of infections in buildings and more as a readout of risk of outbreaks. And so we built these data-driven kind of risk levels where we just looked at our data set and we thought, okay, when you see this sort of concentration, how likely is it that the next sample will have a really high concentration? And so that kind of led us to these sort of very simple risk thresholds, which have associated kind of interpretation for our partners who are sampling at buildings and who may, not know how to interpret the exact wastewater concentration. Beyond COVID, so we and many others are really working hard to expand wastewater monitoring beyond COVID. So we are currently monitoring for mpox across the US as part of our national CDC contract. That data is available on the CDC's website, so you can actually go look at it and see what it's looking like. And then we also recently relaunched our high-risk substance monitoring program. So kind of back to our roots with opioids, we're working on that again. And so here we're providing data on community use of fentanyl, meth, cocaine, and nicotine for a few pilot customers. And even kind of beyond these things we're currently doing, we did a lit review a few months or last year, kind of trying to understand, do we think that finding things in wastewater is going to be the limiting factor? And interestingly, this is a very targeted, non-comprehensive survey, but of the 80 pathogens we looked at from like a variety of categories, the vast majority of them were either like detected or quantified in urine or stool or even in wastewater. And so this is really exciting because I think it means that looking forward, the things that will determine or limit what we want to pursue is much less like the technical feasibility. Of course, we got to figure out exactly how to make all this work, but more really about the need and the opportunity for impact. So that's kind of, I won't like rehash all of that because I know we're close to time, but that's kind of the story. That's what we've done, how we've done it, a little bit of what we learned. We're really excited. I'm really excited about wastewater epidemiology. I think it's just like phenomenal, like how well it works. I think it's important to pause and, not take that for granted. Like biology often doesn't work. And so the fact that the wastewater trends really do reflect cases and is really a powerful part, like, and implemented part of our public health toolkit, I think is just really exciting. And so I invite you to check out our data if you don't already. I use it to figure out what's going on with COVID. And yeah, happy to answer any questions.
Awesome. Thank you so much for that, Claire. That was incredibly insightful and clear. And I'm sure that I speak on behalf of everyone saying that we really appreciate Biobot's contribution to the future of epidemiology and where the whole field is moving. Just as a reminder, if people have questions that they want to ask, feel free to send them directly to me or just to post them in the chat and I can read them out. But maybe just to get us started, I'm kind of curious about the implementation of wastewater surveillance in the context of emerging infectious diseases and diseases where maybe we don't have any kind of baseline signature, because it sounds like with COVID-19, with mpox, wastewater surveillance kicks on after the pathogen has been identified. So how do you kind of reconcile those two?
Yeah, I mean, I think like in all things, wastewater isn't a replacement for any sort of public health surveillance. It's just a complement. And so in thinking about kind of new emerging pathogens, the power of wastewater is that if you already have a surveillance network and something's happening internationally that you're worried about getting imported or you're starting to see cases, you can rapidly deploy, you just need one assay and then you rapidly deploy it to all the samples you're already collecting. And so you can really quickly kind of respond and do a national surveillance. So, that's one thing. I think also if you're doing non-targeted analyses, so like metagenomics or non-targeted metabolomics, you can also generate digital data that you can then go back to in the past, right? Time travel and look for things. So there's a lot of potential there. Yeah.
Awesome. And then a question from Shui Ting that's kind of related to that. First of all, she would like to thank you for a wonderful talk and great to see how much practical development of wastewater surveillance there has been throughout the pandemic, and then especially at the national scale like Biobot did. Ting is wondering more about what are kind of the foremost challenges that you've encountered. I know you mentioned normalization and kind of representativity, but are there kind of other challenges that we should consider as we begin to normalize to a greater extent the use of wastewater as part of our surveillance infrastructure?
Yeah, I think that the challenges are all like logistics and communication and education. And so, right, like figuring out actually how to do this at scale is non-trivial. And like, we're doing a good job, but we definitely haven't figured it out without, any painful parts. Also, the communication is really challenging, especially as you're expanding to new pathogens and especially new use cases where you don't have that gold standard data. So how do you build the trust in the wastewater data? Ideally, one day we'll get to a place where like wastewater works for kind of enough things that it's like, actually, it is the gold standard and it becomes the gold standard. We're not there yet. And so how do we get there? And then like, also, how do you communicate the uncertainty and the like, when we started with COVID, we had these wastewater concentrations and we didn't have enough data to know whether they were truly reflective of patterns or like a random number generator. And yet it was really important to get that data out there and to make sure that people could use it and could use it to kind of inform their response. And so just like that balance of really believing in it and trusting and believing that it'll work and that we'll figure it out, with also communicating about kind of, okay, what does it mean? Like, what's a virus concentration? It's not a case number, right? And so I think those are some of the biggest challenges that have come up over and over as we've, developed the COVID, mpox, high risk substance. I think this is one of it's not technical. It's not like scientific as much as it is really the practical implementation and use of it.
Awesome. I also see a question from Chinchin. Chinchin, do you want to ask your question directly?
Sure. Hi, Claire. Thanks for an awesome presentation and for all of your amazing work. It was really awesome to hear that HHS and Biobot have been working with tribal communities. I was wondering if you could just tell us a bit more about that work, the communications and response from the tribal communities, and also how, if there may be potential biases in who is getting sampled in those communities, as I know that there are often low connectivities to sewer in those communities.
Yeah, it's a really great question. It's definitely not one that I have a lot of insight in, especially with our CDC contract. So I know that like the outreach was really, really intentional and was through kind of existing networks. There's also like one of the biggest considerations is really respect for the data autonomy, right? So they're sovereign nation. And so if a tribal community is part of the data set, like their reporting jurisdiction is not the state they're in. It's their sovereign nation. And like if there's one in Oklahoma, like the State Department of Public Health of Oklahoma like needs to have explicit opt-in permission to access their data. So I think that that's like always at the forefront when we're talking to our government partners about this data, which I find really, really fascinating and really cool to see. In terms of the sampling bias, this is something like, I'll say I wish we had more time to really investigate, because we see sampling locations come in with names like lagoon, and it's like, oh, what is it? And a lagoon is just a type of like treatment plant, like a pond. And so I think that that's not something we've really dug into, of just like, what are these wastewater networks? And it's not isolated to like just tribal communities. A lot of rural communities, right, have, it's not Deer Island, right? It's not a treatment plant with kind of like standard primary, secondary processing and treatment. So yeah, it's definitely interesting and not something we've looked into explicitly.
Thanks.
And I think we have time for probably one more question. This is from Ellen, and she's asking if you could talk about the types of clients that you usually work with and how you're able to kind of combine sustaining the work you're doing at Biobot with a viable business model that kind of balances the work you've been doing with the CDC and maintaining the public dashboards, but then also being able to make this sustainable for the future.
Yeah, that's the $1 million question that I'm sure our founders are tired of answering. So right now, our primary revenue is from government. So It's been really important for us to follow kind of the trends in funding. So early on, the treatment plants were the ones who had kind of CARES Act money that they could throw around. And now there's definitely a shift to more state and federal programs being funded. And so that's kind of, we're adapting our strategy as well to really focus on those relationships. And so that's always going to continue. I think we'll always, we always need to be partners with government because treatment plants are municipal utilities. And so, and we want to impact public health, which is government. Beyond that, I think one of the key focuses for us in the coming year is to really figure out what sort of secondary commercialization of the data can we have. So are there groups out there, organizations out there who could be interested in the aggregated data, maybe to inform some of the, some of the efforts that they're working on. So I don't know how much I'm allowed to share about that, so I won't give any specifics, but I think that's definitely something to think about, right? Like there's a lot of industries out there who essentially aggregate data and then sell that aggregated data to potential users. And so where's the value prop? Where's the value prop that also aligns with public health for the wastewater data, especially given that it's still a fairly new data stream? So great question, and hopefully we find the answer so that we can continue to be a company for a very long time.
Wonderful. So with that, thank you again, Claire, so much for joining us for the seminar series. And thank you everyone for taking the time to listen and ask very insightful questions. And I think we really look forward to hearing more about the amazing work that Biobot is doing in the coming months and years. And just looking forward to see where your professional trajectory goes as well. Thank you.
Cool. Thanks for having me. This is fun.